form that needs to be signed by a doctor so that if EMS comes into contact with a person who doesn't have a pulse, they're allowed not to do CPR. Because otherwise they're under orders to do it, and they're not doctors. They don't know the patient. And if nobody else is around to say don't do it, they kind of have to. But that's what this order empowers them not to do it. And inside the hospital, it empowers our nurses not to do it because it's a doctor's order. And encourage also non-medical planning. You know, a lot of these issues about funeral plans or plans for pets or financial arrangements, when you wait for a crisis to happen, these things become very important. And I've seen them have major influence on medical decision making. I haven't had time to make put these things in order, and so I'm going to accept this treatment, even though it's probably not going to work. And when it's appropriate that a doctor could implement these orders, like a do not attempt resuscitation. We added the A, or the other word I use for it is allow a natural death. Because if I say do not resuscitate, it implies that resuscitation is going to be successful. And we're choosing not to do it. The reality of the situation is dramatically different. Or do not intubate. What if a person never wants to be on a breathing machine? We have to actually say don't do it. Because when a person is in a crisis, we have to give an alternative though. So if we're not going to use a breathing machine, we need to do something to take away shortness of breath. Because nobody should be allowed to suffer that. So if you're not going to fix it, take away the pain and suffering. This website, texaslivingwill.org, is a great resource. And I'll show you the website after the presentation. It allows you to go to the website. You can download forms and print them out and fill them out yourself. Or you can even make the form on the website using your driver's license, and it'll file it electronically, and you can print out a copy for yourself. And so these are the kind of things that are available to be done for free that you don't need an attorney for. But it's usually helpful to work with a doctor ahead of time to understand some issues. But if you already know how you want to be treated in an event where you can't speak for yourself and the doctor feels that they're not going to be able to prolong life without doing certain potentially burdensome interventions, you can use this tool to go ahead and do your own advance directives. Every state has some different rules, so this is really effective for Texas, but a lot of states have reciprocity, or they'll accept something as long as it makes sense. So to talk a little bit more about CPR, there was a really good study that's actually published where they looked at all the television episodes of the TV show ER, and they said, well, how successful was CPR? And on that TV show, and most TV shows, CPR works 75% of the time. When they did a survey of patients and their families who were in an ICU, and they asked them, if your loved one or your heart were to stop, what success rate do you think CPR is going to have? Guess what? 75%. So most people think CPR works 75% of the time. So if a doctor comes and asks them, do you want it? Most of the time the answer is yes, absolutely. And even on the show ER, patients get CPR and they're cured of their underlying problem. They're all better. They don't go on life support. Nothing bad happens, very rarely. In reality, unfortunately, it does not work that way. In reality, for patients who have a cardiac arrest in the hospital, about 10% of people survive to hospital discharge. Of those 10%, a good portion have brain injury and can't function independently anymore. So their quality of life is dramatically changed from their baseline. For patients who have metastatic cancer, it's more like 0% survival. And this is published data, it's reality. This treatment for a lot of patients does not work, but we do it routinely. Routinely. Something that doesn't work. By not working, though, I'm having a different definition than most doctors. Most doctors would say, well, I restarted the heart. It worked. Is that enough for most patients, is just having a heartbeat on machines? For most patients, the answer is no. They want to get better. They want to go back to their life. So the real question is, how often does it give the patient their life back? Not just be alive. And the answer is between 0 and 10% of the time. That's dramatically different than what most people understand. And so now with that information, I would ask the family, based on this opinion and based on these facts, I would recommend that we not do CPR because it's not going to give them their life back. That's a much different response or a much different answer to that question than do you want me to do everything? But this is based on informed consent. This is based on the facts. This is based on good communication. If I just say, do you want me to do everything? Do you want me to do CPR? And you don't have this information, what do you think you're going to say? Yes. Maybe. Some people have strong opinions. But the other thing we do, besides trying to get involved early, is we need to be there also at the end. So in the last hours of life, sometimes continuing to do everything, or a lot of the times, especially everything we do to people in the hospitals, contributes to the suffering. Things that yesterday were life-prolonging and curative, today are harmful and prolonging death. Things like even IV fluids, blood work, having even blood pressure checks. If it's not helping the patient, why am I doing it? It could only have a burden then. Even something simple like checking the blood pressure. Oxygen masks, might yesterday be doing good to keep your numbers up, and today are a gag that stop you from speaking. It's okay to take them off. Most doctors are not comfortable with this because you have to talk about it in the framework of goals of care. What's most important for this patient? Is there anything I absolutely always have to do that's artificial? And I would argue the only thing I absolutely always should be trying to do is help the patient. And if it's not helping, then it could be hurting. And if it's hurting, it's okay to stop it. When I teach medical students, I was never taught this in medical school. I wasn't even taught this in residency. And this only came from really understanding how do you take care of a person. And now, over the past 5 years, this specialty of palliative care has become much more important and much more popular, but not every physician is trained in this. So we're trying to train our medical students with this. We're trying to train our residents to be better at this, because essentially this is what most patients would want. They would want their doctor to explain this, to know how to treat them, to know how to relieve pain and suffering, not cause it. Things like intubations or oxygen saturation monitoring or one more beeping device that just gives you something to look at is not helping. And it's okay to take those things away. CPR, separation from family and loved ones. Why do we have visiting hours? Why do we have ICU visitation hours? Why do we restrict it to 2 people? Well, if I'm thinking I can fix somebody and it might work, it's a complicated scenario, but if it's not helping, then doing these things are just hurting. And it's okay to stop that, or you got to get a person out of the ICU if you can. And this always brings up the ethical considerations, and after the talk we can definitely answer a lot of questions, or I'll be happy to answer a lot of questions. But there's this idea, especially in our community, that if you're not trying to fix something, you're actually hurting somebody, or that if you're giving pain medicines that you're going to end their life, or that all hospice does is make a person die. Not true. Absolutely not true. I would say that these ethical principles apply more to our treatments sometimes, like chemotherapy. We give chemotherapy because we think that it's going to help the patient live longer or fight the cancer. But we know that it can be very harmful medicines, that it can cause death, it can cause infection, it can make you feel bad, cause nausea. It can have all these burdens, these side effects, but we still give it. But I thought doctors were supposed to first do no harm. That's not true. If doctors were first do no harm, you'd be paralyzed. You couldn't do anything to anybody, because every medicine I have, if you read all the potential side effects, there's a whole long list of them. So it really is, what's your intention that matters most? My intention is to help the patient, not hurt them. My intention is to take away their pain, not shorten their life. Pain medicines, if used properly, are very safe. But most doctors are uncomfortable with them because you can have side effects, just like most doctors would be uncomfortable giving chemotherapy. So some doctors who become more specialized in this care are more comfortable using the appropriate doses of medicines to get the outcomes that you need, which is relief of pain and optimizing quality of life. But say even if my pain medicines made somebody live less or would maybe accelerate death, am I allowed to do that? And the answer is yes. Ethically, you can, just like chemotherapy. Some patients I give chemotherapy to are going to live less than if I had not given it. But I'm still allowed to do it. Why? Because I'm trying to help. I'm trying to make a person live longer. Well, we don't give that same credit to symptom control. If I'm trying to help a patient's suffering go away, and as a side effect, they were to live less, that's okay. As long as you have full informed consent and do everything you can not to let that happen. That's reasonable. In other words, correct dosing. Even Tylenol at high doses is an extremely dangerous drug. You have to take it properly. Just like any other pain medicine, like an opiate is. So in the right hands, it's very good. But even if it were to shorten life, what matters most is the intent. And if the intent is to relieve suffering, it's always okay. A lot of physicians are not comfortable with that either. But that's the ethics of it, and that's what's considered the standard of care. And if you look at the textbook guideline recommendations from a lot of professional societies, even when you're looking at diseases like end-stage lung disease, in the guidelines, as the last option, is if all these things don't work and the person's still suffering, use these medicines. But most physicians still won't do it because they're uncomfortable with this possibility, with the ethical dilemma that they think they're actually dealing with, but they're really not. And we do it a whole lot more often, but again, I think it more comes down to doctors are not putting as much importance on relief of suffering as we do cure. But I think most patients would argue, well, if you can't cure, then relief of suffering is extremely important. And I need a doctor who's going to help me do this. And you'll find most of that in palliative care and in hospice programs. Thank you very much. Yeah. So this is usually the most entertaining part, is the questions. Yes?
I have one on back to the CPR. How do you know, my question is, how do you know if the symptoms are they having a stroke or are they having a heart attack?
Mm-hmm.
If they're having a heart attack, sometimes they tell you to don't lay down, sit up straight, and get all this stuff.
Sure.
If they're having a bleeding stroke,
Mm-hmm.
we wouldn't want to give them CPR, would we?
You know, that's a really good question, because it really comes down to this. We don't do CPR on people who are alive.
Okay.
CPR is for people who have no pulse, who have died. We don't do chest compressions or defibrillation with somebody whose heart is beating. So what I would say is, do not attempt resuscitation. Only applies to a person with no pulse. If you're alive, I need to do something to either relieve your suffering or to fix it.
That's something that needs to be addressed, like in these cert classes and places, because they're telling everybody to give CPR and they're training all these people in CPR. And this is misleading.
Oh yes, my biggest criticism is in the protocol. There's nowhere that says when to stop. When do you stop? CPR can go on for hours. When is it okay to stop? Or do you even start it in the first place? But CPR guidelines are written for physicians and non-physicians and nurses. And in the realm of prognosis, this is exclusively in the scope of care of a doctor. Of determining whether something's going to be effective or not is a doctor's decision, nobody else's, presumably. Although doctors love to ask families what they think and put it all on them, but still, in the guidelines, it doesn't work that way. So, you're absolutely right, but the best way to talk about this is plan ahead of time. Because once you're at that crisis, there's no time to think. Our default in our society is do it, and we can deal with it later. We can deal with the consequences later. Person's heart comes back about 50% of the time when you do CPR in the hospital. So when you do this, you'll get a heartbeat back 50% of the time. But like I said, the question is, are you going to go back to your life? Not, am I going to get a heartbeat back? And for that answer, it's more like 10% or less. So the consequences are really a good portion of the people who get CPR won't get a heartbeat back. And if they do, they're going to die on machines. And if you knew that, it's still now, do you plan ahead of time? But and this is where I educate a lot of nurses and doctors, is do not resuscitate does not mean do not treat. If a person's alive, you treat them. We only talk about CPR for somebody who's died, and somebody who has died is at peace. They're not feeling anything. There's nothing more to treat. It's okay to leave it be. Allow a natural death is the other way to put it. That's why this do not resuscitate language is very deceiving. What I would rather say is allow a natural death. It's very clear. If a person has died, I'm going to allow it to happen. I'm not going to interfere. But if a person's not dead, well, that's a different story. Now, if a person's having a stroke or a heart attack, I might have a treatment for that works. This is not CPR. We do have good treatments for strokes. We do have good treatments for heart attacks. They don't always work. But
Not in a hospital, but they're at home.
then they're alive.
What do you do? I mean, just call 911?
Yes, call 911. And this is why it's something you got to plan ahead of time. And the answer is call 911. But if you're in a hospice program, we give you an alternative to calling 911. In a hospice program, if a person gets in distress, we should have planned ahead of time. We should have prepared for medicines in the house. We know this is going to happen. Let's plan for it. And this is what we're going to do if it happens. You're not going to call 911. You're going to call us if you don't know what to do. If we didn't, and we should educate you ahead of time, this is going to be the plan. But if something happens that we don't predict, call us. Because 911 is probably not going to be the answer to this problem. It'll be us. So you give that alternative. You have to give an alternative. You just can't say don't do anything. We can always do something, even if it's just a comfort. I shouldn't say just a comfort. Comfort's very important. Other questions?
You're here
Yes.
at Valley Baptist, but do you go into nursing homes?
I can get consults from the nursing homes and go and arrange family meetings. It's a little difficult to coordinate those things. So what we've done is, I think we got brochures passed out. What we're doing is starting an outpatient clinic. So patients who are mobile, who can get to a doctor's office, we can have an appointment to sit down and talk with the patient and their family and answer these questions in a session. But for patients who can't get to the office, then I can either go out to the house or go to the nursing home. And I've tried to stay inside of Harlingen for that just because of the logistics of things. I can't be stretched too thin. Yes.
CPR.
Sure.
Someone presented a program a few months back at an organizational launch, and she talked about the changes in CPR, and it was like just the breathing part that they were moving away from the compression part.
Sure.
Does the breathing part have any value?
The science behind it really is the most important thing you can do in CPR is try to prevent the brain from dying. That's the idea of chest compressions. And usually the blood has enough oxygen in it from the time a person stops breathing that if you're doing CPR properly and giving that blood to the brain, that's what turns out to be the most important thing you can be doing. And sometimes just the chest compressions alone gets the heart starting again until we can do more advanced life support. And then the advanced life support, we start talking about shocking, or if you see those defibrillators in the airports and the malls and such, for certain cardiac arrests, especially caused by a heart attack, it's the electricity that can get that heart, stop it from short circuiting and get it beating again, because there's nothing as good as if the heart's beating. Even weakly, it's better than what we can do with chest compressions. And this is the problem with CPR, is even if you do the chest compressions perfectly and breathe for the patient and do all that, still about half of patients are going to get, even if they do survive, are going to have major brain injury from that lack of perfusion. The whole brain is not getting blood and oxygen, and it causes damage every minute. So now we're even using more advanced technology here at this hospital that if a person does survive it, we put them in something called an Arctic sun, which is a cooling blanket, and we drop their body temperature very low because it tries to help give them a better chance of, if they survive, that they have less brain injury and that maybe their quality of their life will be better. Again, it all comes down to quality of life. So we do have those kind of tools available, but they don't work very well. But in modern medicine, any couple of percentage points in gain that's deemed to be statistically significant suddenly becomes the standard of care. Even if it only helped 1 in 20 patients who got it, we'll do it. So that's most modern treatments is usually between 1 in 5 to 1 in 20 patients who gets it is going to actually benefit from it. The rest don't get any benefit whatsoever. Or there's a flip side of it called the number needed to harm, where if I treat 20 patients, how many people do I hurt? And if a lot of treatments are even, where for every 1 patient I help, I hurt somebody, that's not a good treatment. But usually these days, most of the stuff that's getting approved by the FDA has those kind of numbers associated with them. They're not perfect, but it was better than the alternative. Yes?
How would you approach a doctor when you know that his patient needs palliative care, hospice, and you know that the patient is better off with those kind of services than what he is doing? Because he's trying to do something that probably,
Sure.
because that's his way of thinking. How do you approach him without them feeling like, what? Who do you think
Yeah.
you are?
Yeah.
It's like,
The way I've done it and been tremendously or more successful than I ever thought I would be is just this relationship building and education and trust in me. So I build relationship with a lot of physicians, not all physicians, okay? Every doctor has different personality, but a lot of physicians in the community can see that it's not a threatening thing, that it tremendously benefits their patients. And the doctors I know all are just trying to do the right thing for their patient. What I would say the person who has the most power is the patient. If the patient goes to their doctor and says, this is what I want, it's extremely rare where I've seen the physician totally disagree with the patient. Usually that's what they were waiting for.
where patients do that. So, I talk to the doctor, the staff, wherever I can get a hold of them, and they're not in agreement with what he wants. So now you go to the doctor and you tell them.
Right, that's usually the best way.
Then the doctor says, what? Do you realize that if you go into hospital palliative care, I'm not going to treat you anymore. You're not going to have any of my services. And he's like, and the patient comes out like,
Yeah.
wait a minute.
The only thing that's going to fix that is if they change the way doctors get paid. I'll be the first to tell you that. That
So it hurts your pocketbook, and they care more about their pocketbook than the patient. And I told
Yep.
doctors that, and they're like, hey,
now, again, this is not a battle you can fight at the bedside. This is something that is more systematic. And so if you look at how do systems